Good morning, everybody. Welcome all the students for this another session of Musculoskeletal system. Dr. Rajesh Patil herein. So last class we had dealt with the basic lesions of the bone, the normal anatomy, the histological aspects of the bone, what are the different cells that constitute the bone structure. Now, in this class of this musculoskeletal system, we'll be dealing with the tumors, the tumorous conditions of the bone, the different benign tumors, malignant tumors, and tumor-like conditions. So, in this particular musculoskeletal system includes the lesions, the tumors, the neoplastic conditions in cases of bone, cartilage, the fibrous component, the miscellaneous. In miscellaneous where you can see like Ewing sarcoma, giant cell tumor, and the metastatic deposits. Now, coming to WHO classification of the bone tumors. So, this can be asked for you as a 5 marks question. So, this is an important one, commonly asked Viva question. Like what are the benign lesions of the bone, the malignant lesions of the bone. The benign lesions, osteochondroma, chondroma, chondroblastoma, chondromyxoid fibroma. So these are all cartilage originated tumors. That is 22%. Chondrogenic. That's what is mentioned there. The malignant counterpart of this cartilage one is chondrosarcoma, dedifferentiated chondrosarcoma, mesenchymal chondrosarcoma. Well, there you can see here this particular part, the myeloma and malignant lymphoma, that is from the hematopoietic components, that can also be a primary lesions in cases of the bone, since bones are the factory for new cell production. So even the myeloma cells, the myeloma tumor can originate from the bone itself. Then osteogenic, from there the bone proper here, osteoid, osteoma, osteoblastoma, these are the benign components of the bone tumors originating from the osteoid. So malignancy, osteosarcoma, that is a malignant part. Then fibrogenic, the histogenesis being the fibrous tissue. The benign lesions, fibrous cortical defect, that is fibromas, non-ossifying fibroma, fibrous histiocytoma, desmoplastic fibroma. Then the malignant one, fibrosarcomas. The unknown origin ones, the giant cell tumors, the unicanal cysts, the aneurysmal bone cyst, that is ABC. That's 3 marks question ABC in itself. So one of the important differentials it forms in a giant cell tumor. The other one is the aneurysmal bone cysts. The neuroectodermal, the notochondral, that is benign notochondral cell tumors. Then the malignant counterparts, the Ewing sarcoma, the chordomas. So this is a table there. Now, management aspects. So the diagnosis, treatment, rehabilitation. So this is an important schematic diagram where you can see from which layer, which part of a bone the genesis of that particular malignant bone tumor takes place. See that particular diaphysis. From the diaphysis it could be adamantinoma, osteoid osteoma, chondromyxoid fibroma. Whereas metaphysis, the lesions could be in the osteosarcoma and chondroma. Epiphysis, chondroblastoma. And here right side you can see the origin, the GCT, giant cell tumors, aneurysm, bone cyst, osteochondroma, bone cyst, fibrous cortical defect, fibrosarcoma, fibrous dysplasia. So the round cell lesions in the histiocytic lymphomas, myelomas, Ewing sarcoma. So all are the round cell lesions of the malignant bone tumors or the bone tumors. Diagnosis. See, always when you diagnose a biopsy or histopathology of a bone lesion, always correlation with the radiological correlation with the x-rays ultrasonography findings or a CT scan, whatever, always report a case of bone lesion or bone tumors in correlation with the X-rays. The radiological correlation is very important during the diagnosis of a bone tumor. Suspected from the history and examination made after the investigations confirmed by the biopsy. So biochemical markers, imaging, CT, MRI, plain radiographs, isotope bone scans, angiographs, all this. So here, the bone tumors, bone proper one, lesions, osteoma, osteoid osteoma, osteoblastoma, osteosarcoma, also called as osteogenic sarcomas. Now in case of osteoma, it could be solitary, middle age involvement, origin, endosteal surface, subperiosteal, sites, skull, face, most common. And this is a totally benign lesion and to be distinguished from reactive bone. Okay. So compact osteomas. So on microscopy, what you see basically, mature lamellar bone, there are no Haversian canals and no fibrous components. So trabecular osteomas are composed of cancellous trabecular bones. So here picture the micro photographs of these particular cortical bones there. Osteoid osteoma at least 2 centimeter in diameter. The size 2 centimeter at least. Involvement in teens, 20s, so 20 plus, commonly seen in males. And appendicular skeleton involvement. It's painful, so caused by excess prostaglandins production by the proliferating osteoblasts. Has a nidus, so response to aspirin induces a marked bony reaction. So important points there. So usually the treatment is radioablation. So this is again the radiogram of intracortical osteoid osteoma. The radiolucent with central mineralization can be seen there. So microscopy composed of interconnecting trabeculae of woven bone that are rimmed by prominent osteoblasts. The intertrabecular spaces are filled by vascularized loose connective tissue. Now coming to next lesion, osteoblastoma. So involvement, axial skeleton, that is spine. Osteoid osteoma and osteoblastoma are terms used to describe benign bone tumors that have identical histological features but differ in size, sites of origin, and symptoms. There is no nidus, no bony reaction, and not relieved by aspirin. So, what's the size? More than 2 centimeters and involves the spine more frequently. Osteoblastoma is usually curated or excised en bloc in a conservative fashion. Osteosarcoma, that is osteogenic sarcoma. So this is the other name for that. But I've seen in the recent film, Dil Bechara, Sushant Singh Rajput was suffering from osteosarcoma. So how they have depicted, he has part of his limb was completely amputated in that particular film. So just to make you remember, I'm telling that particular sequence. So osteosarcoma, late teens, in and around the knees, painful. Metaphysis, the site of involvement. Okay. Types of osteosarcomas, important one, 5 marks question or 3 marks question. The anatomic portion of the bone from which they arise, depending upon that, they can be classified as intramedullary, intracortical, or surface originated one. And then based on degree of differentiation, whether it's multicentricity, like synchronous, metachronous, Primary involvement, pre-existing bone is unremarkable here, or secondary, that is osteosarcoma associated with pre-existing disorders such as benign tumors, Paget disease, bone infarcts, previous irradiation. Then histologic variants. What could be the histologic variants? The osteoblastic, the chondroblastic, the fibroblastic, the telangiectatic, the small cell, and giant cell types. The most common subtype is osteosarcoma that arises in the metaphysis of long bones, is primary, solitary intramedullary and poorly differentiated, and produces a predominantly bony matrix. Gross features of osteosarcomas. Osteosarcomas are big bulky tumors that are gritty, gray white, often contain areas of hemorrhage and cystic degeneration. The tumors frequently destroy the surrounding cortices and produce soft tissue masses. They spread extensively in the medullary canal, infiltrating and replacing the marrow surrounding the pre-existing bone trabeculae. Infrequently, they penetrate the epiphyseal plate or enter the joint. So when joint invasion occurs, the tumor grows into a long tendoligamentous structures or through the attachment site. Now coming to the microscopy. The tumor cells vary in size and shape and frequently have large hyperchromatic nucleus. So bizarre cells can be seen here. Bizarre tumor giant cells. The neoplastic bone usually has a coarse lace-like architecture deposited in broad sheets or as primitive trabeculae. So lace-like distribution of osteoid is the hallmark here, apart from giant cells, hyperchromatic bizarre cells. So that is the key point to be remembered here. Clinical course typically present as painful, progressively enlarging masses. Sometimes a sudden fracture of the bone is the first very symptom. Just a mild twist or turn, or just after a jump. A 20-year male jumps from a step from here and there, and suddenly his bone gets fractured in and around the knee. So that's the first presenting symptom it could be. The tumor frequently breaks through the cortex and lifts the periosteum, resulting in reactive periosteal bone formation. The triangular shadow between the cortex and raised ends of periosteum is known radiographically as Codman triangle and is characteristic but not diagnostic of this tumor. So this is a Viva question or a 3 marks question. What is Codman's triangle? So this is a radiological finding. So this is an important one here. So these aggressive neoplasms spread hematogenously. Okay, the point to be remembered. Metastasis to the lungs, bones, brain, and elsewhere. So a complete Christmas tree will be formed on PET scan, wherein the follow-up is not good enough here. So in cases of osteosarcomas, so when it spreads to every part of the body. Cartilage forming tumors. Osteochondromas, also known as exostosis. Common cartilage and bone is present here, often multiple as a hereditary syndrome, commonly seen in males. Pelvis, scapulae, ribs, the site. See, this is schematic diagram of the origin of this particular tumor here, osteochondromas, this one. See here, the cap outside is cartilage, then down is bone, and then the marrow one. Such schematic diagrams are essential to fetch good marks. Now, gross. Osteochondrums are sessile, mushroom shaped, and range around the size of 20 centimeters, 1 to 20. The cap is composed of benign hyaline cartilage covered peripherally by perichondrium. The cartilage has the appearance of disorganized growth plate and undergoes enchondral ossification. So these are slow growing masses, painful if they impinge on a nerve. Okay. So usually this is an incidental finding in multiple hereditary exostosis. The underlying bones may be bowed and shortened. They stop growing at the time of growth plate closure. Composed of a cap of hyaline cartilage undergoing enchondral ossification. The cartilage cap has the histologic appearance of disorganized growth plate like cartilage. Chondromas. So chondromas are benign tumors of hyaline cartilage that usually occurs in bones of enchondral origin. They can arise within the medullary cavity where they are known as enchondromas, or on the surface of the bone where they are called subperiosteal or juxtacortical chondromas. Enchondromas are the most common of the intraosseous cartilage tumors. They are usually solitary metaphyseal lesions of the tubular bones. The favored sites are the short tubular bones of the hands and feet. So pure hyaline cartilage. So multiple enchondromas could be seen in Olliers disease, Maffucci syndrome if hemangiomas are also coexistent. These are all your questions. Maffucci syndrome and Olliers disease. Enchondroma. So detected incidentally. See this radiograph here of the phalanx with a pathological fracture. This one here. So radiological feature, O-ring sign. What is that? Well circumscribed oval lucencies that are surrounded by a thin rim of radiodense bone, that is C or O-ring sign. If the matrix calcifies, it is detected as irregular opacities. The nodules scallop the endosteum but usually leave the cortex intact. Treatment depends on the clinical situation and is usually observational on or the curative one. So depends usually the treatment depends upon the curettage and the radiological observations there. The solitary chondromas rarely undergo sarcomatous transformation, but those associated with enchondromatosis do so more frequently. So individuals with Maffucci syndrome are also at risk of developing other types of malignancies, including ovarian carcinomas and brain gliomas. So enchondromas are usually smaller, gray-blue translucent, composed of well-circumscribed nodules of cytologically benign hyaline cartilage. So of course they can undergo ossification, calcification. The classical association could be seen in, as I told, Olliers and Maffucci syndromes. Sometimes it's difficult to differentiate from the chondrosarcomas. Coming to chondroblastomas. So this is a rare tumor seen in teenagers. Again, as usual, males very commonly involved here. In and around knees, usually. Epiphysis, the site of origin. So here there is less matrix than a chondroma. So this is a particular the picture. The tumor is composed of sheets of compact polyhedral chondroblasts that have well defined cytoplasmic borders, moderate amounts of pink cytoplasm, and nuclei that are hyperlobulated with longitudinal grooves. Mitotic activity and necrosis are frequently present. The tumor cells are surrounded by scant amounts of hyaline matrix that is deposited in a lace-like configuration. Nodules of well-formed hyaline cartilage are distinctly uncommon. When the matrix calcifies, it produces a characteristic chicken wire pattern of mineralization. So this is important microscopic finding, the chicken wire pattern of mineralizations. Scattered through the lesion are non-neoplastic osteoclast type giant cells. Occasionally, the tumor undergo prominent hemorrhagic cystic degeneration. Coming to chondromyxoid fibromas. What are these? These are the rarest of all the tumors of the bone, commonly seen in teens again, the males. Arise in the metaphysis of long tubular bones but can involve virtually any bone of the body. So atypia, myxoid areas could be seen here. Gross. So again 3 to 8 centimeters in greatest dimension and are well circumscribed, solid and glistening tan gray. Microscopy. So nodules of poorly formed hyaline cartilage with myxoid tissue can be seen here. Cellularity again varies. There could be at the periphery of the nodules in the cartilaginous regions, the tumor cells are situated in lacunae. So delicate processes could be seen here. So varying degrees of cytological atypia. So other findings include small foci of calcification of the cartilaginous matrix. So here the microscopic picture here. So chondromyxoid fibroma with prominent stellate and spindle cells surrounded by myxoid matrix. So osteoclast type giant cells are also present here. Coming to the next lesion, chondrosarcomas. The feature common to all of them is the production of neoplastic cartilage. The production of cartilage here. Chondrosarcoma is subclassified again into anatomically intramedullary, juxtacortical, histologically conventional, that is again hyaline myxoid, the clear cell variant, dedifferentiated one, and then the mesenchymal variant of chondrosarcomas. So chondrosarcoma with lobules of hyaline and myxoid cartilage permeating throughout the medullary cavity. So that's a picture depiction here. So large bulky tumors are made up of nodules of grey-white and somewhat translucent glistening tissue. So commonly you can see the myxoid variants here. So again spotty calcification is coexistent feature here with central necrosis. So the malignant cartilage infiltrates the marrow space and surrounds pre-existing bony trabeculae. So again, depending upon the how is that particular differentiation, the cell morphology, they are classified again into grade 1, that is the lesions demonstrate mild hypercellularity and the chondrocytes have plump vesicular nuclei with small nucleoli. The binucleate cells are sparse and mitotic figures are difficult to find. Portions of the matrix frequently mineralize and the cartilage may undergo enchondral ossification. Grade 3 chondrosarcomas are characterized by marked hypercellularity, extreme pleomorphism with bizarre tumor giant cells and mitosis. So pure grade 3 involves, so chondrosarcomas are uncommon in this particular category. Such malignant cartilage is more frequently a component of chondroblastic osteosarcomas. So other variants could be again dedifferentiated one, the clear cell chondrosarcomas, the mesenchymal chondrosarcomas, again composed of islands of well differentiated hyaline cartilage surrounded by sheets of small round cells. It can mimic like even Ewing's sarcoma. So here you can see anaplastic chondrocytes within the chondrosarcomas. So again, bone fibrous tumors. So these are again, these are not so very important for you to be asked in the exams. The fibrous dysplasia, the fibrosarcoma, malignant fibrous histiocytoma. So these are, commonly asked in cases of MFH in soft tissue lesions, soft tissue tumors, than in the bone. But these are the lesions that can also be seen in association with the bone. The fibrous cortical defect, the non-ossifying fibromas, the fibrous dysplasias. So fibrous cortical defect. So you should be aware of the names, the ossifying fibromas and all that. But not commonly asked for undergraduate level in the exams, this one. So we'll move ahead. One, you should be aware of this one, the findings of storiform pattern. You see, storiform pattern in case of fibrous cortical defect created by benign spindle cells with scattered osteoclast type giant cells, characteristic of a fibrous cortical defect and non-ossifying fibroma. So what do we mean by fibrous dysplasia? What are the types basically? Polyostotic, single bone. So again, just not very commonly asked in your exams, but you should be aware of this particular entity. So this is basically a benign tumor. So involvement of a single bone or the multi-bone, so called as monostotic, polyostotic. So this is again the microscopic picture there. The curvilinear trabeculae of the woven bone that lack conspicuous osteoblastic rimming. Coming to fibrosarcoma or the malignant fibrous histiocytoma, this can now be also seen in terms of bones. Where? In metaphysis, the site of long bones. Examples, pelvic flat bones. It's a lytic lesion basically. The patient can present to you with the fractures. So there could be sarcomatous metastasis. So grossly, these tumors are large hemorrhagic tan white masses that destroy the underlying bone and frequently extend into the soft tissues. They are composed of cytologically malignant fibroblasts arranged in a herringbone storiform pattern. The level of differentiation determines the amount of collagen produced and degree of cytologic atypia. In the past, some of these tumors were called malignant fibrous histiocytoma because the pleomorphic cells resemble the histiocytes. So you can see this is a microscopic picture here. The malignant fibroblasts arranged in herringbone pattern or the storiform pattern, the fibrosarcoma picture. So miscellaneous tumors of the bone, the most important is the giant cell tumors, the Ewing sarcomas. So important one, easily asked for you in the exams, Ewing sarcoma or primitive neuroectodermal tumors, PNET. So small round blue cell tumor, the synonyms, the neuroendocrine cell origin, the chromosome translocations 11 and 22 involvement. Second most common bone malignancy in children. So commonly seen in case of children, the Ewing sarcoma, PNET. Arise in medullary cavity of the bone, look like lymphomas. So they present as painful enlarging masses. So tender, warm and swollen the sites. The gross features here usually invade the cortex, periosteum and soft tissues. The tumor is soft, tan white and frequently contains areas of hemorrhage and necrosis. What is the X-ray findings here? The lytic tumor that has permeative margins and extension into the surroundings of tissues. So onion skin fashion, the layers of reactive bone deposition. Classical iridological finding in case of Ewing sarcoma. Okay, that is onion skin fashion. So basically, it is composed of sheets of uniform small round cells that are slightly larger than lymphocytes. See here. small round cells, just looks like a lymphoid sheets of cells. Scant cytoplasm which may appear clear because it's rich in glycogen. The presence of homocyte rosettes, important, even Viva question. Tumor cells arranged in a circle about a central fibrillary space is indicative of neural differentiation. Although the tumor contains fibrous septate, there is generally the little stroma. Necrosis may be prominent and there are relatively few mitotic figures in relation to the dense cellularity of the tumor. GCT, giant cell tumors of the bone. So giant cell tumor is so named because it contains a mixture of mononuclear cells and a profusion of multinucleated osteoclast type giant cells. The synonym osteoclastoma. So they can ask you as a giant cell tumor or osteoclastoma. Important 5-mark question or a 3 marks question for you. So this tumor is relatively uncommon, benign but locally aggressive neoplasms. It usually arises in individuals in their 20s to 40s. The mononuclear cells in the giant cell tumor express RANKL and the giant osteoclast-like cells are believed to form via the rank-rankle signaling pathways. So involve both epiphysis and the metaphysis. The typical location of these tumors near joints frequently causes arthritis-like symptoms. So important clinical symptom here. How are these? These are large red-brown tumors that frequently undergo. So most of the commonly, these such tumors, the osteoclastomas, are involved with cystic degenerative changes. The cortical thinning that can be seen in the film and in the gross photographs here. So they are mostly composed of uniform oval mononuclear cells that constitute the proliferating component of the tumor. Scattered within this background are numerous osteoclast type giant cells having 100 or more nuclei that resemble those of the mononuclear cells. Necrosis, hemorrhage, hemosiderin deposition, and reactive bone formation are common secondary features. The metastasis. So it can spread to prostate, breast, thyroid. So this is again the pathways of spread, the direct extension, the lymphatic, the interspinal seeding. So the metastatic cells will secrete prostaglandins, cytokines. So there could be cytokine storms generated by these particular cells. So this is again gross findings of this particular lesion here. So metastatic deposits, the area here, the encircled area, it's looking like a foreign deposition, foreign cells there in that particular to the native. So wherever we see osteoclastic, large giant cells or foreign cells, those are nothing but the metastatic deposits. So with this, I conclude this topic of the tumors of bone, wherein saw the different originating tumors of the bone, could be cartilage or could be from the bone proper or could be from the fibrous tissue proper, the fibrous dysplasias or the giant cell lesions, wherein you also seen out how to differentiate these giant cell osteoclastomas from the other differentials, the dedifferentiated tumors, the ABC, that is aneurysmal bone cysts, all this. So myself, Dr. Rajesh here, signing off for now and conclude this particular session. Thank you, students.